I think we might get started. I know more people are joining, and people will probably join as we work our way through the hour. But in the interest of everyone's diary and time, we'll make a start now. So welcome. I'm Terry Quinn. I'm a geriatrician from Glasgow, and I'm also the NHS Research Scotland lead for ageing. Hot off the press, I'm also the UK lead for ageing, but this is predominantly a Scottish selection of slides that I'm going to share with you today. So we've set up these lunch and learn webinars with two purposes. One is to bring in fantastic speakers, and we've got another fantastic speaker this month, Professor Bhattacharya, who I'll introduce later. But we also wanted to use it as a means to let people with an interest in older adult research in Scotland know about some of the opportunities that there were here in Scotland. So I'm going to say a couple of things just about what's happening around older adult research in Scotland, and then we'll get on to the main event, which is our invited speaker. So of course, the first thing that's happening is what you've just tuned into. It's these webinars. So we're running this as a bit of a pilot to see how people engage with it. We had a talk last month by Miles Witham. It was an excellent talk, and we had a lot of people join us for that. And we've got another excellent speaker today. You can mark your diaries for the last Tuesday of the month in May and June, when we've got Emily Henderson and Susie Schenken, who will respectively be talking about trials in Parkinson's disease and trials in care homes. So details are all on the NRS Ageing website, but there is a code there and a tiny URL as well if you want to register. So let me tell you about some other opportunities that there are in Scotland. And the first one are for those people who are maybe earlier in their research career and are looking for a PhD. The University of Edinburgh Advanced Research Centre has a suite of PhDs themed around issues relevant to older adults. The titles of the PhDs are there. They're fully funded. If that's something that is of interest to you, they're all on findaphd.com. And also, if you go to the ACRC website, you can find more details. For those of you who are looking for some training or a bit of CPD, the BLAST network, which is a UKRI funded network with an interest in really biogerontology and that form of ageing research, are running a one-day meeting around careers and opportunities in ageing research. The agenda for the day is there on the right of the screen. Details are on the left. Again, if you just Google BLAST ageing research, you'll be able to get to their website and you'll be able to see more details around that. Continuing on a theme of training, back to Edinburgh University now. Edinburgh University run a very popular research methods course. A number of the faculty may be familiar to you as they come from the ageing research ecosystem. So this is a methodology course that runs end of September, beginning of October in central Edinburgh, and it's affiliated with Royal College of Physicians. So again, if that's something that you're interested in, particularly I know medical trainees need to attend a research methodology course as part of their training, this one is ideal for those needs. All the details are on the slide there. Again, there's a code and there's an email there if you want some more details. Moving from training to research opportunities, I wanted to flag up the SHARE resource. So SHARE is a voluntary resource where people living with various health conditions donate biosamples like blood and their data, their information. And they are then made freely available to the research community. So SHARE at the moment has data or samples from over 300,000 people, and they've already supported over 150 research studies. So if you have a research idea that needs you to access people or information or biosamples, it's worth having a think about whether SHARE can help you. And the details for how you contact Share are all on the slide there. Again, there's a website and there's an email, and they're a very friendly team. So even if your idea is still at quite an early stage, you can email them and you can have a discussion about how Share might help you. One of the main things that I want to do with these webinars is flag up studies that are open in Scotland and that are looking for new sites. And we have one particular study that is looking for sites and that I think would be good for Scotland. It's a study called 4C. It's a study that was created by trainees in geriatric medicine. It's an observational study, so there's no interventional drug, and it's looking at whether hand grip strength and frailty status predicts adverse outcomes, particularly readmission. It's an ideal study if your site or you are kind of new to research. We've got all the approvals for it to run in Scotland, and now we're looking for sites and for principal investigators. So if that's something that you'd be interested in finding out more about, you can email me or email Jackie. Again, our details are on the website. One thing that I think is particularly attractive about 4C is it's part of the associate PI scheme. So at the moment, principal investigators for studies need to be consultants, but we know there are lots of trainees in medicine and in allied health professions that would like to get experience of research. So through the associate PI scheme, trainees can effectively do the work of a principal investigator, but they're supervised by a more senior principal investigator, and at the end of it, they get a nice certificate that they can put in their e-portfolio. So if you would be interested in hearing more about 4C, do let us know. So 4C and the training and all the other things that I mentioned, details for all of them are available through NRS Aging Scotland. Drop me an email, drop Jackie an email, and we'll get back in touch with you. So that's everything that I wanted to say. We're now going to get to the main event, the real reason that you've tuned in, and that's to hear Debi Bhattacharya tell us about her experience of medicines optimisation research. So Debi is Professor of Behavioural Medicine at University of Leicester. She leads a number of multi-centre, high-profile trials in the space of medicines optimisation, particularly for older adults. And she also has a role in trying to create capacity for pharmacists that have an interest in research. So I'm going to hand over to Debi in a minute. Just a couple of housekeeping rules. We are going to keep questions till the end, but you can pop questions in the chat at any time while Debi's speaking, but then we'll answer them all at the end. We are going to record the webinar, and we're going to make the recording available on the website. So that's something for you just to be mindful of if you want to interact with us. At the moment, we've got speakers until the summer. We're going to take a break over the summer, but we'll come back in the autumn. So if any of you have ideas for other speakers that you'd like to hear on this webinar, or other content that you'd like us to cover, do let me know. And with that, I'm going to stop speaking and hand over to Debi.
Thanks, Terry. I should say as well, I have a slightly failing voice. I'm hoping it will hold out. Yep. Hopefully I am now sharing. If I get the screen. Is this all good? Fab.
That's perfect.
Okay. So thanks for that introduction, Terry. And actually, the two studies that were in your introduction are what I'm planning on covering. So CHARMA and IMAB-Q, just covering that pathway for identifying what the issues were and then developing the intervention and then going to large-scale testing. So CHARMA is a practitioner behaviour change intervention. So it's designed to support geriatricians and pharmacists in hospital to proactively stop medicines where the chance of harm outweighs benefit. IMAB-Q, however, is a patient behaviour change intervention. So we're looking to support clinicians to work with patients to identify their key barriers to adherence and then select evidence-based strategies to then support them to take their medicines as prescribed. So that's the two separate programs that I'm going to talk through today. The pathway that they've taken, so with both of them were a fairly long haul. So with CHARMA, the underpinning research, understanding what the problem was, what the existing evidence was, developing the framework for the intervention was all done in a PhD. And then we were able to then transition to a 5-year funded programme grant to really build the intervention so that we had something tangible to implement, do some small scale testing and then go to definitive trial, which is where we are now. IMAP-Q was an even longer haul. So the underpinning evidence, because so much work out there in medication adherence already, that in itself took a long while to kind of unpick what's known, what's not known, and fill those gaps. Then we had secured more funding to develop the intervention, the IMAP-Q intervention. Then we needed to address some uncertainties in terms of trial design because we didn't know what outcomes to use. So I looked at Cochrane reviews, and there are no meta-analyses because they can't pull the data because every adherence study is reporting random different stuff. So I thought, right, we need to develop a core outcome set. So we did that, and then we finally got to the stage where we're at that 5-year program of research. So that's the two programs that I was planning on briefly talking through today. So CHARMA is an England-wide trial. Apologies. Do you know what? The reason I did that is because of the logistics of securing things like HRA and REC approval across the different boundaries. It was incredibly painful anyway doing it. And with hindsight, I don't know whether maybe that was an unfair. So I'd had previously very bad experiences and it had been really challenging. And maybe I think moving forward, I might try to go now across the border and do both Scotland and Northern Ireland in the future. So the problem that we were looking to address with CHARMA was that we already knew 1 in 2 older people are prescribed a medicine where the chance of harm probably outweighs the chance of benefit. That's the issue we were trying to address. So what we wanted to find out is to what extent is hospital doing something about that already? Because it may be that primary care is where the work needed to be done. So what we did is we looked at 24,500 prescribed medicines to see what proportion of those were stopped during an admission. And it was actually only 0.6% of those medicines. So we know that 1 in 2 people are prescribed potentially inappropriate medicine, and yet only a very small proportion of the medicines are being stopped. And in most cases, it's reactive. So only where something bad has happened. So like an ACE inhibitor being stopped if someone's got AKI, or, an anticoag if someone's bleeding. So things aren't being proactively stopped. So the message we got from this work is that less than 10% of older adults have a medicine stopped during their admission, and less than 1% of medicines are proactively stopped before harm occurs. So we could see now that actually it would be viable to do something in hospital to try and shift things so that we are getting more medicines proactively stopped. So that work was published, so we knew kind of what the size of the problem was that we were looking to address. What we then thought is, how do we handle this? Is it that maybe patients and family members actually don't want people to mess with their medicines? They kind of got this acute admission. Do they want the focus to be addressing that and get me out of hospital? Or do they want people to actually look at things a bit more holistically? So we asked patients and members of the family, and actually they were horrified that that wasn't standard care. So they thought that their discharge summary had been really carefully considered, every medication reviewed, and only those that definitely are right for them as an individual were being continued. So that was then a really powerful driver for us to start to work in this field. So we knew there was a problem, and we knew that patients and members of the public wanted us to address it. So now we were thinking, well, what's going on? Patients and family members want this to happen. There's lots of scope for making a change. Why aren't geriatricians and hospital pharmacists doing something about it? So we held some focus groups with them across lots of different hospitals, because we knew that there would be different contextual factors that might influence what the challenges were. And they identified across these focus groups 4 consistent barriers to deprescribing, proactively deprescribing in hospital, and 1 enabler. So what we then did, now that and we had kind of behaviour change theory underpinning this work, is we then said, right, we need them to work with us to design strategies, theory and evidence-based strategies to address these 4 barriers and 1 enabler. So we held some co-design workshops, again across lots of different hospitals, and that gave us the deprescribing implementation framework for hospital. So this is a generic framework underpinned by theory, behaviour change theory. And the reason we did something generic is we didn't want it to be very specific to the NHS. We wanted something that could be, you know, we know that in the US, in Canada, deprescribing is a real priority for them. So we wanted something that could be usable across all healthcare systems, not just the NHS. So, so we've got these 4 barriers with behaviour change techniques. Sorry, my voice is failing. With behaviour change techniques selected to target those determinants, so the 1 enabler and the 4 barriers. The next thing we then did was secure the funding for the programme of research to actually fully develop the intervention and then test it. So this was the programme grant, and it was 5 work streams across 5 years. So the first thing we needed to do is develop a core outcome set, because deprescribing at that time was still quite new, and there were very few trials, and actually CHARMA will be the largest trial internationally in deprescribing. So in developing a core outcome set, we we did a Delphi study. So it's a portfolio study like the one that Terry just described. And what we wanted to do is, via the portfolio, we wanted to recruit 20 to 30 hospitals. And the ask was to then recruit for us 30 to 40 people per professional group. And so that was like geriatricians, pharmacists, nurses, physios, anybody who might be able to comment on what was important to measure in a deprescribing trial in hospital. And we also wanted them to recruit patients. Now, this is quite, so the ask was for healthcare professionals and patients to fill in 3 rounds of questionnaires online, or it could have been on telephone, or it could have been written, but for the professionals, certainly it was online. So we're talking a really low risk study here. Going through capability capacity with those hospitals was incredibly painful. So I think a learning perspective for us is how much time needs to be embedded into a research program purely for organizations to provide capability capacity. And the issue was, I think, is that they were very familiar with running CTIMPs, so drug trials. And so a really low intensity trial where they just need to fill in a few questionnaires, they were treating exactly like it was a drug trial. So it was taking months and months and months and huge amounts of resource for us as a team to make this happen. So I think there is some learning there for the NIHR, really, that they're funding us. We've got these very low risk trial studies, and yet R&D within hospitals are a really significant barrier to getting timely research. And then separately, we were then recruiting academics to help develop this core outcome set. What actually happened is only 5 hospitals went down the route of saying, right, we'll recruit hospital staff for you and we'll recruit the patients and carers. The remaining, we had 10, so we only had 15 hospitals in total. So the remaining 10 said, we'll just recruit hospital staff. And as I said, just this process was months, or we were about 6 months behind schedule, because that's how long it took for R&D within hospitals to give approval for a study that involved 3 questionnaires. So that was some real learning for us moving forward. The result was we successfully managed to finish developing the core outcome set. And so deprescribing trials should be collecting, as a minimum, these 6 outcomes. Of course, there may be, depending upon the intervention, additional outcomes that they collect that are tailored to their intervention. But as a minimum, so that we can start pooling together data and meta-analyses, we need all trials to collect these information. For CHARMA, we're using 90-day hospital readmission. So that's the core outcome set done. The next part is then developing the intervention, because remember, in the underpinning work, we had that kind of that framework, the deprescribing implementation framework. So we need to make it something tangible now. So we held virtual co-design workshops with 3 separate hospitals, and we selected them quite carefully. So we had one that had a really diverse patient population and well-developed pharmacy service, because CHARMA is geriatrician and pharmacist behaviour change. We had one hospital that had really good IT infrastructure, because you'll see with the intervention, there are things that could influence how well they could implement it based on their IT infrastructure. And then another one that was a much more small scale hospital with quite a limited pharmacy service. And this is what they co-designed. So CHARMA has 5 components. You've got that hospital action plan to make it a priority. So geriatricians and pharmacists said, you know, this is what we signed up for. This is what we want to do, is proactively deprescribe, review our patients holistically. But the priority for the organisation is patient flow. They want us to get the patient, patch them up and get them out. So we have a hospital action plan so that it's kind of supporting or endorsing from the hospital that proactive deprescribing is important to the trust. We have workshops for pharmacists, because pharmacists said, we know which medicines have greater chance of harm and benefit for individuals, and we know that it's something that's important to do. But on balance, we think it's probably best not to rock the boat, and better to do nothing rather than risk doing something. So that's why we developed these workshops, where they really get to think about the pros and cons and really get to visualize the bad, that doing nothing is not a no harm choice. So that's the workshops. Then we've got workshops for geriatricians, because they had a misconception that patients and family members would be really resistant to proactive deprescribing in hospital. So we've developed some, I think, quite slick videos. We even have Everdell actor in there, so showing how geriatricians successfully navigating quite challenging, or what looks like quite a challenging deprescribing discussion, but successfully navigating that. We've got benchmarking reports, so feeding in data so that each participating trust can see how many medicines they are stopping, and as a kind of feedback mechanism, so they can see that extra work that they're investing is worth it, is making a difference. And then finally, weekly briefings, so that pharmacists and geriatricians can actually be in the same place at the same time. So that pharmacists, where they've identified opportunities for potentially for deprescribing, that they can share those with the geriatrician. So that's overall the CHARMA intervention, which is published here. So that takes us now to the small scale testing of this intervention and the trial design to make sure that we can actually deliver it before we go feet first. So the feasibility study, we had 3 intervention and 1 control hospital, just to make sure that control hospitals would collect data for us. Findings, I'd say feasible-ish, because what we did in the feasibility study is the PI was the one that was responsible for driving implementation of trauma, because we thought, you know, it's not that difficult. It's a couple of workshops, it's this benchmarking data, and then the action plan. Well, the reality is the PIs, there were geriatricians with full clinical load, you know, management responsibilities. So anything on top of that was really challenging. So even though this was quite low intensity, just trying to sort out the workshop, you know, rallying geriatricians together, rallying pharmacists together was hard work. So so that's why we've learned that getting the PI to do it is not sensible, and it's also not real. You know, in a real world situation, that's not what would happen. So what we've done now for the main trial is we have funding for a project manager to oversee this implementation of trauma. Getting the data from hospital, like med stopped and things, hospital totally fine. Another challenge was we are using data linkage from NHS Digital. Started the process long before the feasibility study to make sure that, because we're seeing what medicines are stopped in hospital, and what we wanted to know is 3 months later after discharge, has anything been restarted? So that's why we needed NHS Digital to provide us that medication data in primary care. Still don't have it, still don't have approvals. Started the process long before the feasibility study. So we have other trials that we know have achieved this. So we know we can do it. The scary thing is, are they going to deliver it in time for the definitive trial? So that's kind of that was our learning from the feasibility. What my main take-home message is, oh my gosh, it's so important to do a feasibility study. So that takes us to the final definitive trial, which is where we are now. So we've also gone for a stepped wedge design. So what we're doing is we've got older people's medicines wards. They have other participating sites. They have to be geriatrician led, and they need electronic prescribing so that we can get the data that we need, like about med stop. So in the feasibility study, we had one site that used handwritten notes. It's just not viable. And given the direction of travel, we know that trusts will be electronic. So it seemed ridiculous to do a trial using a format that's not even going to exist in a few years' time. They need to have reasonable throughput of patients, and everyone that's on the study wards need to receive the intervention. So the way it works is we've got this baseline data collection period where they're just enrolling people so that we can do the readmission rate for them, which is our primary outcome measure. And the same goes to the post-intervention period. So it's really, really low intensity. That's all they're having to do. Every patient that comes through, collect some data so that we can later do readmission rate. And then they've got 3 months where they implement trauma. And then we've got this across 5 steps. So they will kind of so here we've got, oh, there's the other thing I forgot to mention. They've got enhanced data collection. So a 1 month period where we're going to get them to do things like quality of life. What else are we doing? That's the main thing, actually. Quality, and the consultation experience, the deprescribing consultation experience. So we'll get a bit more richer data, and they do that during the baseline period for 1 month, and then after trauma's been implemented for 1 month. And so that's essentially the trauma design. We're currently in step 1 and about to start implementation. So we have 24 hospitals included in trauma. we're powered to see a reduction in readmission rates if we recruit 20,000 patients, and the findings we'll get in 2026. And as I said, the thing that was really painful with it was hard for the core outcomes. It was in another league of pain with getting C&C for this trial. So having a trial where there is really the intervention is going to practitioners, clinicians. R&D really struggled with that, and so some trusts had been working with us for 12 months to try and get C&C and just couldn't do it. They just could not deal with a trial where we're not doing things to patients, where we're doing things to the staff. As I said, I think if this was a drug trial, it would have been a walk in the park, but a low intensity trial where we're implementing something to change practitioner behaviour was very challenging. I think something really needs to happen, because from a resource, an NIHR resource perspective, it was really poor use of resource, both for us and for the NHS, who were trying to get these sites up and going. So moving on to IMAB-QI, so remember that's the patient behaviour change intervention to try and support them to adhere to their medicines. So with this, we had this huge body of medication adherence work already. So we did a systematic review to really establish what was known, and then focus groups to plug the gaps in terms of what was already known about the modifiable factors that can influence medication adherence. And that gave us 30 kind of different barriers to adherence. That we worked with patients, members of the public, to then formulate into statements. So we had a 30-item prototype questionnaire that theoretically should identify someone who's non-adherent and diagnose their barriers to adherence. What we then needed to do was validate it and reduce it, because obviously 30 items is completely impractical. So we wanted to identify the best performing items, ensure it was valid and ensure it was reliable. And we did that. So it's quite a large validation study. And we now know that IMAB-Q is valid and is reliable at identifying non-adherence. So that was fairly recently published. I think that was just this year, or maybe the latter part of last year, that this was published. The next thing is the core outcome set. As I said, there are so many adherence trials out there, but we can't pull the data together. So we developed a core outcome set for medication adherence that includes quality of life, whether or not people initiate the medicine, how many doses are actually taken relative to as prescribed. Then we've got persistence. And then I think this one was quite interesting, that patients particularly thought was really important, is whether whatever intervention was introduced, they felt made sense to them. And the reason they said that was that, like, I might not want to take my medicines because I think that the chance of harm for me outweighs benefit, because the benefits on something I value. And what I get is someone telling me all about the benefits and how, and they're not tailored to me, or, they might give me a pill box. And it was like, this was not right for me. So that was why they thought it was important that trials had some measure of whether or not whatever was recommended or delivered was right for them. Adverse medicine events, like in CHARMA, like for the deprescribing and mortality and death. So that was really recently published. That was the 3rd of April that was published. So where we go next then with IMAB-Q is we now have 5 years of funding. So we will now need to really kind of test the IMAB-Q to see if we can, what support practitioners need to be able to deliver it, then do feasibility, then definitive trial. And the definitive trial at the moment is intended to be delivered across 38 medical practices, and again in England, I'm sorry. So that, if I have time, Terry, so I've got some slides about the incubator and capacity development, but I think probably, do you want me to stop and then, because it's only 2 slides.
Go for it. Go for it.
Okay, so the last thing is that the NIHR have identified that there are a number of professions within the NHS who are not represented, or really poorly represented in their training, development awards, in their grants. So so they really now want to invest in these other professions, and one of them they're invested in is pharmacy. So the incubator for pharmacy professionals to develop research capacity was launched this January. So I'm leading that team, but we are, we span a large number of HEIs, hospitals, employers within community. So what I'm really looking for people to do is to join this network. We've got 3 years of funding to first identify what the key barriers and enablers are to people engaging with research, and then years 2 and 3 we will then design those strategies to address the barriers and enablers and implement them. So hopefully by the end of year 3 we will have built capacity by addressing the key issues. So I'm really wanting to reach out to people at all stages of their kind of research career, so it could be, research is not on my agenda, didn't even really know it happens, not interested, through to, I'm writing grants all the time and I'm, PI and delivering them some of it. So that full expanse, so that we can really learn what the issues are and then design tailored intervention to address it. So if you are a member of the pharmacy profession on here, or even if you're not and you know people, please let them know that this is out there, and we can then start, because what I plan to do is later this year send out a super short survey to really understand what the key barriers and enablers are, and I'd love people to like 80% of the kind of the pharmacy population to be able to reply, so that we can make kind of meaningful changes. Okay, I'm now done, Terry.
Fantastic. Thank you. Thank you. So we're going to open up to questions. We'll let Debbie's voice rest for a minute. You can have a drink of water. So we're going to open up to questions. You can put questions in the chat, or if you raise your hands, I think I have the power to unmute you. We'll find out. So selfishly, when I chose speakers, I chose speakers that I wanted to hear and that I had questions for. So I'm afraid I've got some questions. And the first one I wanted to ask was the core outcome set. So you're deprescribing core outcome set, and your title, you said it was for secondary care. Do you think it would look different in primary care? And the one thing that wasn't there that I thought might have been there, but would maybe feature in primary care, would be something about treatment burden. You're on mute there. Sorry.
I'll just say that, we'll just share it so that we can see what it looks like. Treatment burden. So treatment burden. Yes. So treatment burden was there. So we've done something slightly different to what often happens with core outcome sets, in that we assessed acceptability and feasibility of measurement. So it is something that's supposed to happen, but rarely does.
Yeah.
So treatment burden, there were just, in fact, I think, so we looked at I don't know if I can find it. No, medication related burden questionnaire,
yeah,
and various other things, showed them to our patients, members and public, and they said, no way are we ever doing this, it won't happen. And so that's why, as a core outcome set, it just didn't make it. So I suspect primary care would be no different.
Okay.
So I think our learning, though, and actually the core outcome set, one of my team members is really wanting to pursue work in that area, because getting engagement from or meaningful participation from older people was really challenging. we had underestimated how hard it would be. So we had things like, as I said, they could do it written, we could telephone them. A lot of them wanted us to visit them in the home. It was during COVID, we couldn't do that anyway. It was, But even without that, if you think about sustainable research methods, I don't know how practical it is to visit people in the home. So how we meaningfully support older people to engage in this type of thing, I think needs a lot more work, a lot more thought. So, for example, the core outcomes. So, you know, it's a crazy long list.
Yeah.
We sent it out to them in advance, and then the researcher rang people. And of course, you know, then they're trying to process this written stuff. A lot of them were actually answering it like it was their own medicines. Rather, you know, that whole concept. So they were saying like number of prescribed medicines. They would say, oh yeah, I take 8.
Yeah.
You know, and it was the whole concept of a core outcomes that was incredibly difficult for them to grasp. So I think we need to do a lot of work to really support older people to participate.
No disagreement at my end. I think you're absolutely right. Another thing, I mean, still on deprescribing. I guess in practice and in research, you can think about deprescribing in 2 ways. There's kind of system-wide deprescribing, and that's what you're doing in Charmer, or you can hone in on a drug class, you know, say benzodiazepines or something. I'm not an expert, but I think I see more of the latter. I see more stuff around, you know, a targeted why did you choose to go for the whole system approach?
So we think about from a behavioural perspective, there are some real merits in really focusing on a specific medicine and identifying what the behavioural determinants are of deprescribing that. So, for example, stopping a benzodiazepine will be very different potentially relative to, I don't know, an ACE inhibitor or something. So I can see why people do that. The issue is that it is a system. It's not so if one targets one interval and we all have finite capacity, then what is it that person is now not doing that they were previously doing, which then becomes unsustainable. So this is why for Charmer we needed something that would operate within the existing funding model, the existing infrastructure. If it doesn't work, it doesn't work. But at least if it does, we know that is sustainable.
No, I'm with you. You were very honest about some of the challenges, particularly, you know, at R&D level. NIHR and CRNs are being completely redeveloped with this move to RDNs. What's your feedback? You know, if we can change something, what would be your big win, do you think, that would make things easier in the future?
I really felt for R&D. So I was surprised. I have to say, I was surprised at how unfamiliar they were with non-CTIMPs. Really surprised. So I think so CRN were fabulous in terms of trying to actively, so the East of England was the lead CRN for this, and so the person there was meeting with R&D departments individually. We're talking like 40 plus R&D departments. I mean, that was crackers in itself. And so they were having to really focus where they were doing that. So I think generically there needs to be higher level national training or something just to. So there were a number of issues that from a behavioural perspective. You know, first of all, there was the knowledge issue. Of not actually even understanding what the heck this is. Then there was the issue of this being unfamiliar, and actually I would rather do something that I know what I'm doing than invest time in something that I don't really know what I'm doing. And then the other issue was then the national drive to focus on commercial studies as well. So that whole was like a perfect storm of R&D just not one. And then you got the geriatricians that saying, oh my gosh, we're going to get 1,000 accruals for doing nothing. Please, can you do this? Please, can you do this? And there was, those that didn't make, like I said, we had 40 odd trusts that were in the running, 24 made it. I had heartbreaking emails from the geriatricians that said, I've worked so hard with, I've spent hours and hours with them, and what happens now? And I'm like, I'm really sorry. So I don't think that should ever happen again.
Yeah.
I think the other thing, and you alluded to it before, is that we have insufficient capacity for PIs as well in aging studies. This is a huge problem. And then there's the CRN, of course, and aging is a kind of the poorer cousin in general, is perceived as a poorer cousin. So then we've got less CRN. There's so many problems that we need to work with. Yeah,
I mean the PI one is hopefully one that we can sort out. And associate PI, I'm pretty excited about associate PI actually, because
so in Charmer we've done that. We have associate. We've embraced this associate PI scheme because it's quite a low. It's not a drug trial, so it's a low risk study. I think it's really, really important that we get more people, and not just geriatricians, all healthcare professionals. Getting that associate, getting the PI status to be able to support aging studies.
Yeah, and to reassure you, we are working to reduce the pain of opening things in devolved nations. So, you'll never get a complete once for the UK approach because legislation is slightly different.
Yeah.
But we are working to try and minimise the amount of additional work you need to do, so it's not a barrier.
Like the NHS digital, would we have had to, I don't know, is that national coverage?
Oh, that's a good question. I don't think it's this side of the border.
Yeah, see how did we couldn't even do it for England. What would we do if we were doing Wales and all that? Yeah. It's not ideal at all.
So it's not easy. So I've been hogging you and I've not let other people ask any questions. Have we got, I mean, I'm mindful we're almost at the hour now, and I see some people have joined and then left again because they've got other commitments. Anyone else, any questions for Debbie while we've got her? A couple of people just saying that they need to go, but did they enjoy the talk? No, I think I've hogged you so much, everyone has to now go and do other things. But Debbie, thank you very much. I mean, that was a fantastic talk, and I'm sure when we put it on the website, we're going to get a lot of engagement with it. Hopefully, next Medicines Optimisation trial we'll see at this side of the border, and I may be back in touch to talk about how we can maybe make things easier for opening up non-CTIMP trials in older adults. But that
would be amazing.
That's for another time. For
Fabulous.
now, thanks
Good
everyone.
to see you. Thanks for joining all. Bye.